All right. Everybody, this is Richard with What's Your Business Plan. Chuck Pennington, Kyle Johnson from the Follow-Up System, and Dr. Jay Lamar from Yes Doctor. Um, we are going to have a great conversation today with Dr. Lamarca. He's got a very wide background, and he's got some products and services that he provides that are quite beneficial, quite useful. In fact, I have a friend that's using it right now, and he's going to take a few minutes to tell us about himself, and then he's going to go into what Yes Doctor is. So, Dr. Jay Lamarca, could you tell us a little bit about your background?
I sure can. I will try to not give you the encyclopedia version. So it all started a million years ago when I grew up in Chicago, Illinois. And then in high school, we moved to Beverly Hills, which is where I went to school and then on to college and so on and so forth. And my parents are both clinicians. Well, they were. They're both gone now. But my dad was a surgeon and my mom was a clinical psychologist. So I had the bug for healthcare since I was about 3 years old. All the kids in class used to say, what do you want to be? And they'd say fireman, astronaut, sports, something or other. And I was like, I'm going to be a surgeon. And the teachers would look at me like I was the weirdest kid in the world. But they just go, oh, okay, I think we know who your dad is. Anyway, so flash forward to my adult career. I found that clinical medicine was not really a great fit for me. It wasn't that I didn't enjoy it. It was that I wanted so much more. And I wanted to be able to touch thousands of people. I didn't want to touch a couple of hundred. I wanted to be someone that could be influential in other ways. I was a really early adopter to personal computing. My very first personal computer was back in 1981. And back then, no one even knew what that was practically. It was, we talked about mini computers and we talked about mainframes. But a personal computer, that was something entirely different. Believe it or not, mine ran on CPM, if you guys know what that is. It's an ancient system that no longer exists. But this was definitely before the standardization of DOS. So I had that bug too. And learning the program was something that it was just fascinating. It was puzzles. And I loved puzzles. But then, you go to college and you realize you need to focus on one thing. And so I ended up doing cell and molecular biology and then on to med school. But all the while I was in med school, I was building my own computers. So I knew that this plan of mine was going to have to be changed somehow or other. So I matriculated directly into informatics after med school. And I worked for a healthcare organization here in Southern California that's one of the largest for-profits in the United States, called Prime Healthcare. I worked for them for the better part of a decade. From there, I call it Prime University because I got to learn everything about hospital management, hospital operations, and informatics and how that relates to healthcare, so HIT. And while I was there, I got really entrenched in EHRs. So everything from Meditech to Epic, Cerner, Allscripts, Paragon, you name it, I was in it. And we were implementing. I actually took on the role of being the director of training, and I was responsible for training 80,000 employees. It was quite an undertaking. It was literally like building a school. After my time there, I went directly into consulting, and I worked for most of the big consulting firms and traveled around the world helping other hospital systems to implement the same sorts of systems, but I was always working on process. For me, it was always about how do we use this technology in order to make the welfare of our patients so much better. I believe that computers in most ways are superior to human beings with respect to error making. So human beings have the emotional component that a computer can never offer. But with what they do is they can repeat the same sequence of events thousands and thousands and thousands of times with flawless accuracy. Whereas a human being is always going to be touched by whatever happened to them that morning. Was the coffee right? Was their wife nice? Was their husband nice? Whatever it is, right? There's circumstances. People rub you the wrong way. You bump your elbow. It changes your mood. Computers don't care about any of those things because they don't care. Right. So I was always thinking, how do we use this to our advantage? So when smart logic came in play with EHRs, I was in love with it. For me, it was like, this is exactly where we need to be. I'm not saying that we should ever take the decision-making away from the physicians and the caregivers. No, never. But what I think is that if you give them the guides, then they've got much more accurate targets, right? So when they see a differential diagnosis that's been presented to them by virtue of nothing but data, just facts, no opinion, then they can use their craft in order to make the decision and how they're going to approach the patient, how they're going to manage them, what meds they're going to use, whatever interventions they're going to choose. So as things moved on, I just realized that this was something that I was always going to be a part of.
That is great. You don't find too many doctors who have the horsepower, the mental horsepower to say, well, I'm in med school, I'm also building computers on the side. But the background is very interesting. Hey, Chuck, you want to throw in any comments? Because I saw you nodding and smiling quite a bit.
Yeah, no, I mean, it's wonderful to approach AI data and analytics in a way that is humanitarian, that can serve patients, that can help doctors, nurses, the whole staff, the whole system of a hospital run more efficiently and provide a better patient experience. I come from the side of fighting insurance companies, so it's like my experience comes on the tail end of the whole hospital process. And I know from your resume, you worked with some of the larger, and just like you said, Epic, Cerner, Meditech. I've also worked with those on the receiving end of the electronic data, electronic billing process. That's where the follow-up system picks up and starts applying those same sorts of attitudes towards the money recovery side of things. So it's awesome. And Richard, you kind of chimed in on it, the doctor tech relationship. You don't see that a lot. And that's the cool thing about working. I mean, in the follow-up system, we work with several hundred commercial facilities, DOD facilities, the VA. So you get a huge data set that a lot of people don't necessarily have their finger on. And when you look at it in that way and gather the trends, the patterns, and in the healthcare side, in the actual patient care, that means health. That means people living, so it's wonderful to see that. And it's great that, a doctor can take a systematic approach to it like that.
So I can quickly comment on that. You are playing to my heartstrings, by the way. Thank you for that. There were two people at Prime Healthcare that were incredibly influential. One fellow by the name of Ajit Kumar and another one by the name of Shrikant Goti. Shrikant was my CIO, finest CIO ever. And Ajit was one of their highest level C-suite people that was involved in everything related to reimbursement, recovery, clinical documentation, rec audits, you name it. And those two gentlemen trained me with the approach that you just mentioned, using the electronic health record in order to be efficient. And what really changed the way billing took place was really when electronic medical records were fully implemented, because none of the other things had to take place anymore, because every single click of the mouse meant a charge to be dropped, because it was an action, it was an activity. And so this is really cutting edge if you think about it, even though we've been doing it now for nearly 20 years. But in real effective sort of descriptions, it's only the last 10, 12.
Yeah, I mean, we've been digesting it and sort of eating it for a while, and now we can sit back and digest it and say, oh, okay, this is what this is starting to mean. And in your app, Yes Doctor, I mean, being able to more in real time monitor the health situation of somebody and be able to report that and bubble that up into the environment where the doctor is saying, or the nurses or whoever needs to say, here's what's happening with this person. I mean, it's a lot. It's similar to kind of what's happening in the financial side. We have the follow-up system, and the thing that I always said is we need to triage these claims, just like if you were to get inundated in an ER, the whole process at that point is triage. It's putting resources where they are going to be most effective and where they're going to save lives. And, when you have a more robust medical record. And when you can transfer that to billers and make effects and read the data and then report back into the front end of the system to make all that stuff happen smoother, is one thing we always tried to do with the follow-up system. And the other I come from third-party recovery firms, so we're always trying to report back into the system things that would help them have better patient care and things like that. So it's just wonderful to see that sort of activity going on.
Well, Dr. LaMarca, I've been dying to hear you talk about Yes Doctor 24/7, because a friend of mine's using it. Mr. Stan Cottrell, who's doing his run across the United States. And I've known him since I was knee high to a grasshopper. Oh. And there's been a time or two where where his health was a concern.
He told me.
Mm-hmm. Yeah, I mean, I remember calling him and going, "Stan, you sound weird." He goes, "Yeah, I died yesterday. They shocked me back to life." What? and he goes, "Yeah, I had a heart attack on the side of a 285 in Atlanta, and
I was dead for a little bit yesterday."
Luckily,
somebody stopped for him. Yeah, he told me that story. Two very nice people saved his life.
Yeah.
Wow.
And so, with him, and so he grew up with my dad. Our heartstrings are connected, and so knowing that he's got a device that what you're offering, monitoring him makes me feel better. If you could just take as much time as you want, what is Yes Doctor? What is 24/7 Solutions? And the screen is yours. Tell us about it.
Okay, so Yes Doctor 24/7 is our branding for our RPM solution, which is remote patient monitoring. 24/7 Health Solution, by the way, is just the parent company. We don't market that. We just market the brand. And we have co-branding as well with some of our affiliates. Nevertheless, we offer the platform. I'll explain to you first in very broad strokes, and then we'll start to get to the details. Remote patient monitoring has been around for about a decade. The reimbursement for it has always been a little bit on the iffy side. So we had a trial period that lasted roughly about 7 or 8 years, and they kept on sort of dangling the carrot and saying, we might make it permanent, we might not. I'm referring to CMS, and I'm gonna need to put a remote patient monitor on him too. So, so I'm sorry to make light of that.
No worries. It's live.
So the initial idea behind remote patient monitoring was, can we track patients over time? Can we witness via graphs the kind of information which would show trends? And can we help patients to improve their health and well-being through very small changes using this information? So in my opinion, the answer is unequivocally yes. But we have to get a lot of people on the program in order to really get that heavy data and start to drill down and show, in this demographic, we have this improvement with this measure being added. If we add 2 measures, we get this much change. And if we add 3, and so on and so forth. Is it the immediate interventions that matter? No, it is not. This is over time. So RPM is a long process. But what it helps to do, though, is first and foremost, you start out by wearing the device, right? We call these sensors. It's not a watch, even though it looks like a watch and it tells time, it's a sensor. Sensors come in all shapes and sizes. They're cellular, they're Bluetooth, they're everything, right? There's all kinds of stuff. Bottom line is, CMS mandates that these devices are reportable electronically and continuously. So that's what matters. In order for you to get reimbursement, you need to use it for 16 days a month. We have to have data for 16 out of the 31 days of every month in order for you to be reimbursed. That's not a problem for most people because I'm interested in 31 days. I'm not interested in 16. I want the whole picture. So what we do is you start out with, first of all, what does the person suffer from? Because we're talking about principally chronic conditions. There are certain cases where you can use RPM in acute circumstances. It's not the norm. It's the exception rather than the rule, but it can be used. A perfect example would be if you had a patient that was currently being treated as an inpatient and then was released home for something like, let's say, some heart event, like cardiac event. And previous to this, they didn't have any chronic condition. So it would be warranted to monitor that patient from the moment that they leave. So that would be the acute circumstance. Everyone else, we're talking about patients that have chronic conditions, beginning with cardiac conditions, COPD, hypertension, diabetes, obesity, mental health, you name it. There's a long, long list. And more people have them than don't. So the thing is, what can we do in order to help these people make good decisions on a daily basis? Also, what can we do about putting the doctors that are treating them on notice? And what I mean by that is not to scold anybody. There's no reprimand here. This is a help. What we're trying to do is we're trying to say, Dr. So-and-so, you're treating this patient for heart disease. Do you realize that the amount of medicine that they're taking may be inappropriate because of these trends? And nobody has to tell them that. They get to see the graphs themselves. So, like I said, it's more of an oversight. So what we offer in our solution, I'll go back to our solution, is we provide this sensor, which we produce, but we can use any. So our platform is 100% device agnostic. And we happen to work in an environment, meaning the United States, where cost containment is very, very important. So yes, we can create devices that will track every single thing about your body. No problem. You can do it. The cost is enormous. So you need to focus on the heavy hitters, the diseases and the disease processes and disorders that are what the 85% of the population is suffering from, not the 10 or 15. Because if you really want to carve this out and make people healthier, work on that big piece of the pie. Don't work on the little piece of the pie. The little piece of the pie we'll focus on after we've tuned the big piece, if that makes sense to you all.
Absolutely.
Oh, yeah.
So this monitor that we provide, and we provide this, unlike most RPM companies, at no cost. So other companies usually require you to purchase the sensors. It's very variable is how I would put that. It just depends on the company and the platform and whatever they're supporting. There's no one way or the other. There's a lot of different options. We try to, at my company, we try to develop something that would really hit a lot of people, and it would be effective for those people. And if we get a patient population that is very specialized, we'll work with the doctor in order to make something custom for them. So if we have a particular kind of patient, for example, we had an ophthalmologist, and an ophthalmologist, this, other than blood pressure and stuff like that, is really not going to be terribly interesting to them. But macular degeneration, on the other hand, very, very. And so we have our developers working on a portion of the app where they need to look at the app and they need to comment using the app on where do they see the two dots? Do they see the halos and things like that? Because that's preliminary, right? That lets you know you got early macular degeneration, and that's something that the docs want to be aware of so they can start treatment early. Because the earlier the better, absolutely, 100%. So going back to the device. So our device tracks, first of all of your activity, just like a Fitbit or a Garmin machine, or Garmin watch, or any of that stuff. It also does temperature. That was implemented principally because of COVID. Today, temperature readings and all that kind of stuff, it's not so incredibly valuable, but it's nice to have. So why not just leave it and give it to everybody? Our device tracks the vitals. It tracks BP, SpO2, which is pulse oximetry, heart rate variability, HRV, and stress. I told you already, temperature, heart rate, and on top of that, it gives you a sleep report every morning. So when you wake up, you swipe over to the reports, and it tells you in minutes. First, it says when you went to sleep. It says how many minutes and hours of deep sleep you had, light sleep, REM sleep, and then when you woke up. The advantage of using that, which most people kind of think is cool, but they're like, what do I do with it? Well, it gives you a lot of clues as far as how well are they sleeping. If you get low REM sleep, then that's a clear indication that you're not rested. It also means there's a good possibility that something's going on. And we don't jump straight into apnea. Everybody wants to do that. That's not necessarily the problem. It could be a lousy pillow. It could be a pain in the butt partner. It could be a crappy mattress. It could be a lot of things. It could be temperature in the room. Right? I don't know about you guys, but when it gets warm, I'm up. I'm waking up. It's no good. I need a refrigerator. Yeah. I've completely turned into my father. It's horrible. Anybody that's next to me is in trouble because they're going to need a lot of blankets. So back to the RPM story. So what I said earlier was it begins with awareness. By having this tool on your wrist, you have an enormous amount of information that's being delivered to you all the time. Marry that to the app and you get to see the trends. So the app is on your smartphone. Now, in our target audience, which is the Medicare age folks, even though it could be anybody, I'm just going to say that's the bulk of our practice is Medicare folks. Most of them are probably not going to pay terribly much attention to the app. Some will. You're going to have some folks that are they're going to geek out just like me and love it, and it's going to be amazing. Other people are just going to be like, so long as the data is getting sent to my doc and somebody's paying attention to it, I'm okay with it. Yeah. Well, that's the beginning. The second part of this is if they realize they're starting to feel uncomfortable, and then they run the vitals and they see their BP just shot up, did they forget to take their meds? Did they forget to drink water that day? Did they forget to do a bunch of stuff, right? How's their activity going? They can see how many steps they took. And there's all the information is right in front of them. It even tells them what time of the day they did the most amount of their workouts and stuff, and when their heart rates started to spike. When was that? These kinds of things, whether we realize it or not, it becomes intuitive when you notice them, and you start to change your behavior. You'll also get contacted, by the way. So our platform, I'll move to the platform now. So the platform itself, we call a dashboard. Dashboard has all the patients on it in each practice. So every physician practice will have their own set of patients. There's no commingling. It's all HIPAA compliant. It's all in the cloud. They can access it from anywhere on the planet. The dashboard itself has its own intelligence built into it, and we set the limits. So for every data point that we are collecting, there is a range which we consider normal and which we consider out of range. And so the doctors have the privilege to tell us what do they want them to be. We have default, but that's not for us to make that decision. That's for the clinician to make that decision. If they tell us they want it to be a wide range or they want a narrow range, you got it. That's my answer. Whatever you like. They can change it themselves or they can ask us to do it. It makes no difference to me. They appoint folks in their offices to review these patients. In order to comply with the RPM qualifications with CMS, it requires a minimum of 20 minutes per month per patient. The contact with the patient, you should also do at least one per month. One time you should reach out to the patient, whether it's by a phone or text or some form of communication. That's up to you. We decided that for most clinical practices, it was somewhat difficult for them to manage this. Hiring additional staff members just to do patient monitoring is somewhat intimidating for standalone doctors and practices that may be working on a tight budget. So because the reimbursement for RPM is actually pretty great, all things being equal, it's upwards of anywhere. It can range from $160 to $200 a month, depending on which state you live in and what Medicare reimburses for those regions. But that's roughly it if you do it this way. So that would be for 40 minutes. And they allow up to 1 hour, but most patients don't need more than that. If you have a certain situation where the patient requires more monitoring, then that would be more advanced as far as illness goes, and then that's all okay because you just have to do more documentation. That's fine. But for your average patients, 20 to 40 minutes is going to be right in the sweet spot, and it's going to be effective for you and for the patient. The time that they're being monitored, there's a variety of things going on. They're reviewing all of the data points through graphical representation, and if they want, they can look at right down to the dailies if that's what they're interested in. For me, it's more of a monthly thing. That's what I think is more beneficial because when I see the curve and there's always the normal lines between them, and if you see that it's getting close, then to me, I would say that patient is pretty much on target. you see one or two data points that go out of the norm. Those are anomalies. Those are, in a way, unimportant, because so long as that only happens once in a while, then we're not going to get alarmed about that. If it's something that's continuous, absolutely, that mandates an intervention. So what I would suggest, which we have built into our platform, is that the patient is then reached out to directly. So in order to finish the conversation about how do the clinicians manage this, we developed a call center full of trained medical staff. The call center does the monitoring for the physicians and relays the information in the dashboard and can communicate directly with the clinical practices. So how that works is they tell us when you want us to call them, when you want us to call the patients. Again, this is wide open for them to, as clinical practitioners, that's their decision to make, not ours. And so, like I said, I never want to take the power away from any physician ever. It's not my job, it's theirs. So when people start saying, well, then you're practicing for them, and I'm like, no, not at all. All we're doing is monitoring and giving them the information. So when the information is then transmitted, we can send them direct messages in the dashboard. We can call them on the phone. We can text them. We can send them emails. It's entirely up to them. So my vote is give it all. Send them all. Blast them out. Let them know. If this patient needs to be called in and an appointment needs to be made, we can do it for them, or the practice can do it for them. Because if you see that clearly this person's blood pressure is not being well managed, or their SpO2 is tanking, that means their oxygen saturation is not good. It means they're not respiring correctly. Then an intervention needs to be made, whether it's medical or surgical or whatever it may be. That's up to the clinician to decide. But nevertheless, I want them to know, and the patient also needs to know. They also need to know that there may be behavioral modifications that need to take place in their lives. And the other thing we like to do is we like to loop in other caregivers like family members. So if we're talking about mom and dad, grandma, grandpa, great grandma, grandpa, then odds are people, they get comfortable. It's not that they're ignorant or stupid or there's a problem with their thinking. They get comfortable. They get sort of loose, and it's, you can't get down on somebody for that. And you don't want to yell at these people. What you want to do is you want to encourage them. You want to say to grandpa, hey, how many pieces of pie did you have today? It's like, not stop eating. More, are we aware that you're salting the heck out of your food? Things like that, right? So I believe that it's more or less a community effort. And I think Americans as a whole have really, we've deviated from where we need to be as far as taking care of, sorry, my light just went off, my sensor. See, we're all connected. Anyway, so we've deviated from the way things used to be in the so-called old countries, right? Whether it's the Asian folks or the European folks or African folks or wherever, the caring for the elderly in the United States is it's a secondary thought. It's almost just, file that away. If that means put them in a home or a skilled nursing facility or whatever it may be, this kind of stuff just it hurts me. I don't support it in the least bit, but I understand it. Little anecdotal story about me. When I was in med school, so I went to med school in Hungary, by the way, and I happen to be somewhat of a linguist. It's one of my hobbies. And when I got there, I already spoke 4 languages, so I was like, what's the difference? One more, I can pick it up. So any language I can pretty much learn in 6 months. That language took me 3 years. Wow. It is second most difficult language in the world after Japanese in grammar. Pronunciation is another story. It's brutal. So long story short was I was going to clubs, and the girls are so freaking beautiful. It's like you're going to figure out how to communicate one way or another, believe me. So I'm going to the bars and the clubs with a dictionary in my back pocket and showing them it was hysterical. When I look back at my 20-something-year-old self, I'm like, I was an idiot and nuts, and it was the best time of my life. So after a while, I became pretty fluent, and when we were doing our rotations in the clinics, the vast majority of the inpatients are going to be elderly people. That's true here too. That's just medicine. And I would see all the students go in and out, and they would do their thing. And you have to do these long H&Ps because that's what we're learning how to do history and physicals. And it's a painful process. It really is, because first of all, you're nervous. You're not really comfortable talking to strangers. We're still basically kids. We're getting our feet wet in this whole thing, and it's awkward as can be. And I don't like awkward. And so I would see my fellow students doing their thing, and I would just sort of approach some elderly lady or man, and I'd sit down, and one of my passions is cooking. And I'd see, you know, somebody's grandma right there, and I'd say, hey, can you tell me something? How do you make your potatoes? And they would look at me like I was from outer space. Like, are you a moron, or did you get hit in the head? Or I mean, I got that response a few times, and I'd laugh. And I'd say, no, I'm just not interested in giving you a barrage of questions about your past sexual experiences and when you had your last menstruation and all the rest of the stuff that I'm forced to ask you. And they would laugh like crazy. And I really wasn't trying to be a stand-up. I was just trying to make it pleasant. Right. But what I realized was that I loved talking to old folks. I mean, they had the best stories because they already lived. Their whole life they've done everything. I mean, war stories and so many different families and loss and joy and all that kind of stuff. And I'm just like, I'm eating it up every day. And I'd call home and I tell my mom, all these great stories or whatever. And this just stuck with me. And so when I came back to the States and I saw how we take care of the elderly here, not everyone, obviously, but it just it's wrong with me. And so that's why I want to make this process, this RPM, to be something that we can keep people at home longer. It's just filing them away somewhere else and requiring them to have a nurse nearby because their health deteriorated so much. It's just not the way. I mean, so Stan Cottrell. Stan Cottrell is 78 years old and he runs 30 miles a day. I've never run 30 miles in my whole life. So when I say that I'm sure that this is just a matter of conditioning and us learning how to manage our lives over time and making good decisions and going easy on the cheeseburgers, not necessarily completely gone, but you know what I'm saying? And more on the veggies and maybe some fish most of the time, as opposed to always hitting the heavy saturated fat foods, which are delicious. You know, that's the kind of stuff that we have to keep reminding ourselves. So I'm all about this sort of process where you give yourself a little pat on the back throughout the day. You give yourself encouragement. Beating yourself down is the dumbest thing ever, by the way. That is ineffective. It doesn't do any good. All you do is hate yourself for it. And hating anything is awful. So when it comes to yourself, the person that you need to love the most, because if you don't, then you're ineffective. It's sort of like if you go back to this, you guys all know who Abraham Maslow was?
Mm-hmm.
Yes. Yeah. Okay. So one of my biggest heroes of all time, when he created the pyramid of needs, the hierarchy of needs, that told me everything I ever needed to know about the human condition. And he was so accurate. And all he did was ask simple questions. Who is the most important person in your life? All of the most high-performing people in the world, in every single possible career, whether it's a teacher, a fireman, a CEO, a president, it didn't matter. They all said, me. Because everybody else depends on me. And if I don't put myself first, what are they depending on? Right. So accurate. So we get back to the elderly folks and keeping them at home and loving them and taking care of them and giving them little reminders and coaxings and stuff like that. We got a good thing going here. We can definitely take care of people longer. We can keep them out of these goddamn hospitals, excuse my language. But, you know, every single time I hear about somebody that's going in the hospital and they're elderly, my heart sinks.
Yep.
Yeah.
Because that is a place where you go to die. Yeah. When I hear somebody fell, I'm like, oh, no. The broken hip syndrome is like the kiss of death 95% of the time. Yeah. And all these things are so avoidable if they were maintained, right? So the calcium loss wasn't there. The atrophy in the muscles wasn't there. The health considerations as far as diet and all that kind of stuff is present, and people are doing better. Anyway, I'm on a soapbox. I apologize for going on this.
Not at all, man.
That's fine.
You're hitting a lot of very salient points right on the head. And my wife's mom just passed away. She had COPD. I can imagine if she had one of these devices on and there was a push network to where she was saying, hey, her ox levels are going down at a extremely rapid pace, and that pushes a notification to your team and says, hey, doc, man, you got a patient that's going, and she's either going to end up in the hospital or she's going to end up, passing. And so, she had an event during the night, and she passed away. And it could have, with this device, in a proactive environment. And that, to me, while you were talking, the word proactive versus reactive just started pummeling.
Absolutely.
And that's the very wonderful thing about Yes Doctor and this positioning, is that you're putting medicine in a proactive position instead of reactive, which is where we all are right now. We go to the doctor when something happens. I mean, wouldn't it be wonderful? I mean, Maytag refrigerators. They say, hey, you sign up, we'll tell you when your refrigerator needs service. If they can do that to a refrigerator, I mean, you're proving every day on a daily basis that if we just monitor the data and have a properly configured push network, that these dashboards and these teams of people can get in front of these problems. Let's not have a person get sepsis. Let's not have a person have bone loss and then fall just because they could have had a calcium supplement or something. And that, in the follow-up system, that's kind of what we do as well on the back end, is try to be proactive. It's like, what have the payers been doing to you? And how can you take that knowledge and keep them from doing that to you in the future? How can I take my AR days down from 45 to 30? Cash on hand and all that. And these days, I mean, we're talking about hospitals closing their doors.
Oh, yeah.
Rural hospitals. For me, it's rural hospitals and the veterans. I mean, for me to feel that a veteran who served this country has to drive 200 miles, that a young woman has to drive 300 miles. I mean, Texas is huge. To deliver a baby. I mean, bad things happen when you're delivering a baby and have a 300-mile trek. I mean, it was the doctor, the Good Samaritans that saved him. Had it not been for those two people, he may have passed. So I mean, it's what you're doing here is just incredible, and it's a paradigm shift of the entire health network, as far as I can see, and to be able to serve an elderly community. And you're right, they're not going to pay attention. I mean, my mom has a back pain sensor that's controlled by a little iPad, and she doesn't pay attention to this eye thing. She has the guy come and do. They just need.
Understood.
The really freaking cool thing about your process and Yes Doctor is that all they have to do is put it on, and then the rest just happens.
Pretty much.
So I mean, that to me is
you need them to open the app once a day, but that's about it.
Yeah, I mean, but golly, I mean, my mom and dad, they have medicines out the wazoo. 30, 40 different between them. It's 20, 30 bottles of medicine.
All kinds of ideas for that too. That's another problem.
If you could monitor like a serum level of these things and say, look, man, this person is obviously not taking their blood pressure medicine over the past week or so. So Kyle, I think you wanted to jump in there.
I did. When I really grasped what you were up to, Dr. Marca, it really spoke to me. My father passed away in December before COVID got started in 2019, and I would love to have had that, been able to look at the information. He wouldn't have been up for it, but I was his caregiver, so I would have loved to have had that information because of all the medicines he was on. He had a degenerative brain disease, and it had him on some blood thinners to counteract atrial fibrillation and all this stuff. But he ended up dying of a stroke, and so it had, in retrospect, you would see it'd been good to at least explore what was happening and have a broader picture.
And to be able to pull in the caregivers, I mean, that to me really hit home. I was like, holy crap, I can get a text alert if my mom's condition goes sideways.
Oh, yeah.
Wow.
No,
that's huge.
I want my mother-in-law and mother to be using this stuff because, they're the closest one is 3 hours away. The other one is 3 hours away by plane. And, just to get a notification, hey, give so-and-so a call real fast and make sure they're doing okay because it got pushed an alert. That brings a lot of comfort because there's been a lot of times in which we find out after the fact, oh, who went in the hospital last night or last week? And it's not a fun feeling to find out about it from the rearview mirror.
No.
I've got a quick question, doctor.
Mm-hmm.
I'm thinking of a particular person who's real close to me, early 50s. Went in to see a doctor about one issue, goes to get off the examining table, falls to the ground because they didn't feel their feet. And they did some blood work, called them back the next day and said, no, here's normal, here's high, here's OMG, and here you are up here with your blood sugar. And type 2 diabetic, early 50s. And it turns out that, they knew that they were driving a car on dirty oil for a long time, and they knew they weren't doing the right thing, and kept kicking the can down the sidewalk, and all of a sudden they couldn't kick it down anymore. And this close friend of mine, they changed their diet, and within 90 days, their blood sugar was normal, on the high side of normal, but normal. Mm-hmm. At the 120 and 150 day mark, the doctor was like, there's nothing in your blood work that indicates type 2 diabetes. They didn't do medications. They just, I'm going to go out and do my walks. I'm going to eat properly. No soft drinks, laying off the breads. And what do you say to a 50-something-year-old, who they don't feel old, they don't think they're old, but they reach that point where they realize, hey, I need to start monitoring some things. And, and what do you say to them to say, hey, check out Yes Doctor, because I think this might be beneficial for you. And, and nobody needs to know that you're doing it, just you and your doctor and your wife, and do you have many people who are joining who are in that category?
Oh, absolutely. So age is not the limiting factor. It's just the condition. So if you have one chronic condition, just one, and that could be a variety of things, then you're eligible. So so private payers also pay. I couldn't tell you what the scale is because I focus on the Medicare, Medicaid side of things, but there's always going to be a small copay that's going to have to be incurred under most circumstances, unless you're very low income, and then sometimes that can be waived. But in most circumstances, there's still some kind of a small copay, and so some people may be apprehensive about that, but I wouldn't be personally, especially if I'm concerned about my health. The circumstance you're talking about, it happens a lot, actually, and I have found from my colleagues that the most effective way to manage when you have someone that has incredibly high blood sugar that didn't otherwise have that was to flip to a vegan diet. So when you go to vegan, the likelihood of you reversing the problems of with respect to your blood sugar is very high. Whether it maintains that or not, you're going to have to obviously get the blood work done. And so, you got to do the A1C and the glucose sticks on glucose monitoring on a regular basis in order to really prove that it's working. Otherwise, they may have to add some drugs, whether it's insulin or one of the other metformin or glucosides or whatever the doctor chooses to treat the patient with. But awareness is where it starts. And so we actually have a glucometer that we use as well. That's made by it's called iGlucose. And what's cool about that one is the little strips. They're actually hard plastic, so it's not difficult to use. And you stick it in the top of it rather than the bottom of it. And then the little pinprick takes the smallest possible amount of blood, and you can watch it, and it tells you when it's done, and then it transmits the data automatically to us. You don't have to do anything. So awesome. That's diagnostic, by the way. All the rest of RPM is non-diagnostic. It's just monitoring. Okay. But that's kind of a really cool thing that we also engage. I am very glad that your friend is doing much better, because that is a horrible situation. Right. When you get the peripheral neuropathies and ulcers and things like that, that's really a very, very, very difficult thing to fix. And usually the eyes are the next step that they've really got to be careful with, because once you get the diabetic retinopathy, it's bad news. It's just not great. Doesn't mean you can't manage it, but it's not great.
Well, I'm very pleased it made just an incredible turnaround. I mean, he was a little on the heavy side. You know, 5'9", close to 300 pounds.
Nope.
And he's
big.
After 6-7 months, he was down to 180 just by
Wow.
changing his diet. And I was like, you know that 120-pound loss, that's like a healthy ninth grader. You lost a ninth grader. And so it's you know, my kids are competitive swimmers, you know, and I am shocked at how often I will see young teenagers who are in the pool and they got the little thing attached to their arm where they have no diabetes. I mean, it seems to be so much more prevalent than when we were younger. And so anyway, they dump sugar into the sugar nowadays.
Yeah, that's true. And I think the other thing is the optics, right? So our visibility for problems is much better.
Yeah.
So it's everything from, you know, how the conspiracy theories start, you know, like, oh, vaccines cause autism. And then people with a straight face say, well, can't you see how many autistic people there are? And I'm like, no correlation whatsoever. That is completely false. It's a matter of us being able to recognize these things before we just called them a little strange. I remember very well in school, there was always one or two kids in the class that were a little off.
Yeah.
You know, it's not like we gave them a hard time about it. It's just, you just kind of knew those kids kind of stayed to themselves and did their thing. And some of them were smarter than whips. And you were like, what's the deal? You know, yeah. And then someone said the word savant and you're like, ooh, that's cool. What is that? And you're like, you don't want it.
Yeah. Well, we're coming up on the hour. What I'll do is one of the first things I'd like to do is before I start posting videos is kind of like have a 2-minute video of you just saying, here's my name, what I do, what I'm about. If you could take 2 minutes to say whatever you'd want an audience to know, and that'll be my trailer video that I post a couple days before I start posting the others.
Okay.
So here's the director saying, roll.
That's the clapper. So, hi, I'm Dr. Jay LaMarca. I am the CEO of Yes Doctor 247. We are an RPM service provider. Our focus is on helping people to make very small changes in their lives on a daily basis in order to have long-term benefits. Our aim is to help people to take control of their health. What we want is we want them to be in charge of everything that's going on with their body, and we want to give them the tools to do it. We use every possible technology solution that exists in order to make this happen, one of which is a sensor, looks like a smartwatch, another which is an entire network of people that are looking to monitor and help you by tracking your data points and looping in your physicians. So this is what we are trying to do, and this is what we aim to help the entire world in owning this part of their life. Rather than being reactive, we want them to be proactive. And that's what RPM is all about.
Well, thank you very much. On a side note, I've got a question that I think I know the answer to, but I know in about 90 seconds, my wife's going to ask me, and if I don't have the answer, I'll be corrected. I swim a lot. Mm-hmm. There's a device. Can you use it in the pool?
Yes. Okay. So it's water resistant, just like your cell phone would be. I don't remember the depth rating, but I want to say 3 or 5 feet. Generally speaking, is what most electronic devices that have water resistant ratings have. You can swim in it, you can shower in it, you can get it wet all you want. It needs to be charged once a week. It has a great battery, and you just need to wear it and then turn on your app once a day so that it can sync because it's a Bluetooth device, right? Great. One thing I didn't mention earlier that I probably should have is the appeal to the physician practices goes in 2 parts, right? One of which is that they are improving the health of their patients, right? The other part is actually with respect to their bottom line. It's rather lucrative. So if you are a typical PCP or internist and you have, let's say, 300 to 500 patients that are eligible, that alone would yield somewhere between $20,000 and $45,000 per month. It's a significant income boost. And what I like about it is when you have that cushion of income that's every month, that means you don't need to see 30 patients a day. It means you can spend more time with your patients, which is the way doctors used to do it. When I used to work with my father, he would spend upwards of an hour with his patients before he would finish. Like his surgical consultations were usually an hour or more. Today, I would be hard pressed to see anyone that spent more than 10 or 15 minutes with a patient.
Right.
There's just not enough hours in the day for them to get through their patient load. And reimbursements as a whole are always up and down, up and down, up and down. Chuck, you can attest to all of this.
Well, that's a whole other conversation we can have on a different
Absolutely.
day. I'd love to have that conversation with you. I'm in,
100% in. So anyway, I just wanted to mention that because it is really an attractive offering. So when CMS came up with this concept, they literally put a mountain of money on the table and said to the doctors, just take it. And all of them said, no, it's too much effort. What do you mean too much effort? No, it isn't. But really, you had to carve through this, and it isn't until, I have to say, believe it or not, COVID is the thing that really will launch this, because everyone in the world learned telemedicine works.
Yeah,
everyone learned that, and we didn't learn it because we wanted to learn it. We learned it because we were forced to. I mean, I got my baptism last year. I got my colonoscopy, right, and my gastroenterologist had to do the entire workup and consultation over FaceTime. Yeah. And I mean, I thought it was kind of comical, actually. I'm like, I'm a physician. It doesn't really matter. But he's like, no. We got to make sure, everybody says they know things. They don't know things. And I'm like, okay. I'm like, fair enough. But bottom line is, everybody I know had the same experience. They all, you didn't go into the office. Everybody's so afraid of getting whatever, Anyway, so that alone has really helped people to understand that we can manage a lot of things from the distance.
Well, Dr. Marca, many blessings to you, and yes, doctor. And looking forward to having future conversations. Chuck, I'll turn it over to you and Kyle to close us out.
Yeah, I would ask the doctor, where can people find you? If people want to find out more about Yes Doctor and what you're doing, where's the best place to go to find out more and how to get signed up?
Certainly. So our website is yesdoctor247.com.
Okay.
And the best way to get signed up would be to contact their physician, their primary care physician. Because one of the caveats with respect to RPM is they need to be existing patients, right? So people don't solicit patients in order to join the program. They need to be their patients. It's fair, because they're following them.
Sure.
Anyway, so, and then if they tell them, hey, I saw this website, yesdoctor247.com, and I'm really interested in it. Would you consider enrolling us? And then from there, I'll take it over. From there, it's a piece of cake. All I got to do is have literally 25 minutes with any physician, and they're gonna sign up.
Awesome.
That's great,
man. It's a wonderful thing you're doing. I mean, to get the whole, basically the whole view of American healthcare in a proactive instead of reactive state, to me is absolutely huge. And to be able to have a data set like this, to where opioid crises and COVID. Pandemics that basically start, if you didn't see the data, they would just start under your nose, and it wouldn't be till there's a problem that you see that. And with the proper analysis, man, you can interrupt trends that are happening that are bad, and forward trends that are helpful.
Yes, absolutely. You can get way ahead of these problems. Another thing I should have mentioned earlier was our aim is principally to reduce hospital readmissions, ER visits, urgent care visits, and catastrophic events. So catastrophic events are things that we can try to avoid, right? So if we're way ahead of these problems, those things don't even exist.
And how many catastrophic events have Richard, your dad, and your dad, Dr. LaMarca, if I had only known sooner?
Of course. That's it.
If we would have just been able to catch this weeks ago, months ago, years ago, I mean, how many conversations like that can we avoid? I mean,
And had other people in the loop.
Yeah.
I'm thinking of all the populations that could be benefited by this. I was an office manager for a community mental health center, and we had a Medicaid, Medicare clinic for walk-in, and we had a program for a personal care home. We would go and pick up people in the community and bring them in. They would get therapy, they would get fed a lunch, and they would have all throughout the day individual therapy if they needed that. But I thought, what a wonderful gift it would have been to the people that were running the care homes, that they would have someone that would be able to monitor this at-risk population, and they wouldn't get left behind, because they had a lot of challenges, a lot of illnesses, a lot of behavioral challenges. It's a wonderful thing that this technology is available, and you're spearheading it with Yes Doctor. It'd be very interesting to see how and for someone that was part of the management, if I had known that, oh wow, that money's on the table, that would have been like, hey, this is doable, it's worthwhile doing. It'd have been an easy. It just, we had a meeting one day and say, we got to contact you. Let's get these people on it. This is a wonderful thing.
I agree 100%. 100%.
Awesome.
The mental health thing is a really big deal.
Yes.
And you mentioned opiate crises. I better watch your guys' time because I will talk forever. But the main thing with addictions and all the rest of that stuff, it all starts from your desire to get out of the circumstances you're currently in, right? So we self-medicate. How do we do it? We got a lot of varieties of ways. Some people are hypersexual. Some people eat too much. Some people drink too much. Some people try drugs. Some people do adventure sports. Whatever that thing is that makes you stop feeling bad, that's the thing you do. And then that's where the addiction goes crazy. It just spirals out of control. And if we can get ahead of those problems, now we're talking about real improvements.
That's right.
Absolutely. Yeah, I mean, I'm glad you mentioned time. We are at the top of the hour. I want to be respectful of everybody's time. Richard, Dr. J, goodness gracious, we could, just like you said, we could talk for hours, and probably will here in the future. So
I look forward to it.
Love to have the conversation about the reimbursement side of this and how insurance companies are treating this kind of technology. It's encouraging that you're actually encouraged by the uptake of this, and that CMS has actually put money on the table. That's awesome. So Richard, we'll leave it to you to wrap up.
Right.
Doctor, thank you so much for being here with us today.
My pleasure.
Marca, thank you so much. Well, everyone,
I'm happy to join again.
Thank you very much. It's an enjoyable hour and is much more informative than I think any of us had imagined, except for you, Doctor. You knew what you were going to talk about. All right. Well, everybody, from the follow-up system, from What's Your Business Plan, and from Yes Doctor, thank you very much for watching, and we will see you on LinkedIn the next few days. Thank you much.
Bye-bye.
Bye.